Hi, everybody. It is Kevin and Thea from RPH Ally, and I am super excited to announce that this is the first episode of Thea's show in remote care services. So, the remote care services show, episode 1. Here we are.
Here
Thea,
we are. Welcome, welcome.
Yeah. So, first episode, Thea and I were just talking off camera here, and really trying to delve into we hear so many phrases, Thea, of RPM, CCM, TCM, LMNOP, all of these things. And, we kind of assume folks know what's happening behind the scenes, what has happened. We saw the pressures toward telehealth with COVID, but you and I kind of got to a point where we thought, where the best place to start is the beginning. And so really getting to a foundational understanding before we try to make the appropriate shifts so the pharmacy world participates and owns their role. I mean, you and I are all about that. You got to own your role, but we got to talk about who's owning it now and where is it currently living. And you were saying, let's do something easy. Let's just focus on chronic care management, right?
Yeah, I think chronic care management is a great place to start when you look at what the opportunities are out there right now that are similar to the things that we understand as pharmacists. And chronic care management has been around for years, and it's really not new to us, but it is. From a CMS standpoint, it's not new, but there's a lot of buzz around it because it can be done from a telephonic level. So you don't have to be in person to do it. So it got a lot of hype during the pandemic because it was an opportunity to gain revenue for private offices and any office, any physician office, and really be able to offer in the insight of where the patients were, because the patients weren't leaving their home. We were all sequestered at home. So, how do we get that information on our chronically sick patients? And chronic care management really allowed for that to happen and really had a lot of growth, so much so that in 2022, CMS came out and said, this is so valuable, I'm going to add 55% increase on its reimbursement. So they felt the need in it as well. So I feel like, starting with the basics of what chronic care management is and who's doing it today. There are some offices, we'll start with the latter. There are some offices that are doing it privately. They have a nurse or an LPN or even MA doing the work of calling the patient, checking in with them, and seeing how they're doing. This can go from, there's 12 points of a chronic care management care plan, and they're very similar to what pharmacists know how to do. Really looking at what the medication problems are, what are the chronic conditions we're trying to treat? What barriers do the patient have to be able to be compliant with those programs? Also, what is the action plan for that person? What is the goal that they're trying to meet? And you set those goals for each patient. So it's not a one and done. It's very personalized medicine that you're doing with these phone calls. And people are get all scared about, oh my gosh, I have to know all these regulations and all this stuff. And I say, utilize a platform that helps you augment that and come up with the best platforms. And I know Kevin and I have talked a couple of different times about platforms and what to look for. And that'll be an episode later, I'm sure, all in itself. But really looking into, the 12 points. You could do it on a spreadsheet and just literally check the boxes of all 12 points. There's not a lot of data that has to go behind these phone calls. And so,
yeah, if we're talking about kind of the baseline, what are clinics currently doing by themselves or hiring an outside entity to do so? The outside entity, you and I know, they're trying to streamline things, trying to automate things as much as possible. I won't get into my very biased Kevin the pharmacist opinions on those things yet, because I'll let Thea say it for me. But they're using an automated service, an outside service, to be able to do some of these things, some of these checkpoints in-house. If let's say we know a primary care clinic in our area, right, that we're a pharmacist working however, and we're I could do chronic care management. How can I help? What are they doing right now? What are they doing? And describe some of the pain points behind what they're doing current status. No pharmacist involved.
I think in rural America, no one's doing it in those offices. I think so. The opportunity there, especially if you're in a rural location, there is a plenty of a need to get involved with that primary care office and really offer some opportunities there to collaborate. Now, people get all worried about that word collaboration, and I'll come back to that again in another video about just collaborations. But really think about it as a service agreement. You're just offering to help, and really laying down some guidelines of where you're going to help and how that's going to look, and really just diving into being able to help augment those patients that may already be coming to your pharmacy, or that because they're church members, or you know them from Cub Scouts. So there's lots of opportunities to already know these people, and it's really just extending the olive branch to, how are you? Like, my conversations with these patients are literally, how are you this month? How's that blood pressure running? What exercise are you getting? Because it's winter in northwestern Pennsylvania. I know I ain't exercising outside right now on the ice. So, like, trying to just meet the patient where they are, which pharmacists are really good at. That was what we were trained to do, is meet the patient where they are. Because you're going to have to talk to them, and you're not going to be able to know what that patient come to your counter is asking next. Like, oh gosh, the questions you get. So I think that, being prepared for those conversations is very similar to what we would know as, going to the pharmacy counter and answering those questions for the patient. So feeling like pharmacists have the ability to do that is, I'm 100%, I'm 1,000% on board that pharmacists have every skill that they need to be able to go in and offer services like these. It's not recreating the wheel. CMS has a toolkit. You can go on cms.gov and look for CCM toolkit, and you'll find it. It's right there. It outlines everything you need to know about what this program could really look like. That is actually going to be a reference or a resource in my channel as well, going in to the resource section. But I'm sorry, Kevin, what?
No, I think that's perfect. I think what you're saying, Thea, on those things, and I can see my internet is being weird, so apologize if it's slow for you at all. But what I was trying to get to on the side of like getting those baseline components, you grabbed onto it so well, in that they're not even doing it. Like, providers are not even doing it right now. So unfortunately, if they're not doing it right now, you have to be able to connect the dots so they know why it's important and how you can do it and how you can kind of funnel some things over. And the one thing, Thea, that you and I talk about so often, like you were saying about, those real conversations and connecting, and pharmacists already knowing how to do that by counseling, at the counter, doing MTM services, that the gap really isn't that wide. So now let's say we have a provider's office, they're not doing it at all, and pharmacy is positioning to be able to get into that kind of first step and that mindset. You work with a lot of pharmacists, and you've worked with a lot of other entities. What do you feel like is the biggest barrier right now, Thea? It's funny because you just mentioned this on your channel the other day. Like, what are the barriers to entry for pharmacy to kind of recognize? And you said mindset. Like, that was the first thing that you're like, it's all about the mindset to offer these services, right? So when we're saying here's current status, it's either somebody is doing it with a nurse or an automated service, and they're kind of passing everything over, and they're checking boxes. How do we get our mindset right? Say, here's how we can do things better, even in a location that's already doing it, and especially to be able to sell the value in a location that is not.
Yeah, I think the easiest way to sell the value of why you want a clinical pharmacist, or any retail pharmacist, any pharmacist doing these service, is really the fact that we're trained to know what's wrong with a prescription. We're trained to know what's wrong when we look at medication adherence. When you look at these outside services, I'm going to go deep, Kevin. When you look at these outside services, they have MAs doing the work. They have scripts to say to the patients. And then who triages that high reading or high value? Who's it going to? It's not going to anyone with clinical background until it hits the doctor. And so I say, okay, wait, hold on. You trust me as the pharmacist in your community to answer every question in the book that you bring to me, but you're allowing a medical assistant who has zero pharmacology behind them to make decisions and ask outreach questions about how medication is working for the patient on a chronic condition, and they give a script. A, where do you triage it to? That's the first question I have. B, how long do you think a patient is going to sit for scripting? I've worked with patients more than 3.5 years, and I can tell you it's hard to build that relationship when it's a cold call, right? Like, I'm just picking up, hello, neighbor down the road. I've never talked to you before. It can be done. I've done it. But to get that call every month over and over and over again, is really not a script. You have to meet the patient where they are each call, because I mean, some days they'll be doing great, other days their dog will have died, and you have to be okay to have that conversation. And I just don't feel like some folks would know what to say in certain circumstances, especially around, the hard conversations of mental health and death and, being chronically sick. Some of these patients are cancer patients. What are the next steps with hospice? What are those palliative care measures going down the road with them? Because no one's answering those questions. So you get the gamut. And if it's not for them, it's for their spouse or their mother or their child, or, and pharmacists are so positioned well to be able to actively listen and really tenderly give empathy and care via a phone call. And I don't think a lot of people have that, especially in healthcare today.
You hit on like so many great pain points. So just to illustrate like to the audience, like the things that Thea is hitting on that make it essential for a pharmacist to partner with an individual office, and recognize that right now pharmacists cannot bill for this on their own. Like we have to have a partnership with an office, usually through an incident to billing kind of situation.
Correct.
But Thea touched on a few things. One, here's a major pain point. You want to do this. How much time is it actually going to take from you? Most of the time talking to providers, they say, Kevin, I work 8 hours. Like people think I work 8 hours seeing patients. I work another 4 hours doing documentation, billing, et cetera, et cetera, et cetera a day. So I've got a 12-hour day. So doc, you want to add on this service that you feel like is essential and is going to drive revenue. How are you going to do all the triaging? Would you rather have someone that is an expert in the individual space, knocking it out of the park every time for your patients, increasing their trust in you so they're not looking to move on to another care provider? Yeah, you probably do. So here's an easy way to do it, be able to use a pharmacist. Next piece is all the drivers Thea was just hitting on, like, how's your blood pressure doing today? Are you doing exercise? Really those kinds of things, they seem so simple, but when you have a trained individual that is good at what they do and can answer those detailed questions, you're able to drive metrics. And Thea is a metrics woman. I mean, and her and I can geek out on data all day, but I guess those are the two like main points I wanted to highlight when we're talking about like thinking about getting into the space and why it's so valuable. You got to hit on, here's the pain point for the doc. You don't have time for this. You need an expert doing it, because if you don't, it's going to drive more either pain through patients being dissatisfied or you having a lot on your table. 2, detailing things out so you can drive metrics to be able to hit those HEDIS measures or look at individual stars or whatever the case is that you're looking at. An FQHC one time told me, Thea, they had 126 different metrics that they had to try to boil down to 13. But all of those pain points are drivers. And if you don't have the right person behind the wheel, like a Thea, or like one of you that can do it, that's fully capable as a pharmacist, I think that's that's a golden ticket. All right, Thea, I think those are wonderful starting points. Like if someone's not excited about doing RPM and realizing like, I could do this, it's very easy. I'm already literally doing it. I'm just not getting paid for it. I hope they think that now. So for the first show's wrap up, any words for kind of the next episode and what people should be looking forward to seeing in your channel?
I really think that next for me, it would be really pulling it in for the pharmacies, right? Like really pulling it into that mind of a retail pharmacist and what this can offer. Because on my LinkedIn, I have a lot, and even through RPH Ally, we have a lot of retail pharmacists in the background watching and observing and taking it all in, but not mentioning anything. And I want to bring this clinical service into a mind that they may understand. When I compare chronic care management to medication therapy management and what those reports look like, I really think I want to dive in there, because I think that will drive the example of care management doesn't sound like a pharmacy thing. It's not a pharmacy thing. And actually it's very much, it's one point. I talked about the 12 checkpoints. One checkpoint is different. One checkpoint is missing. So stay tuned for that, because I really feel like that will be a place to go next, because it'll bring in some of that mindset of a retail pharmacist and how you're thinking about them in these clinical services.
We had one question I want to answer before we sign off here, Thea. Sure. And Todd, one of our good supporters of RPH Ally from Pharmacy Podcast Networks. Thanks so much, Todd, for taking a listen. And he says this: if a community pharmacy owns, separate entity, a home care agency, which cares for the patient's ancillary health needs, why couldn't you bill for RPM directly with a nurse practitioner or business leader? This is a 2 new revenue streams versus 1. And I think he's right. I'll let you take that, Thea. But I think just in general, like, we've got to find ways to be able to partner. If we own an outside entity or if we don't, like, we're seeing the writing on the wall with Walgreens, CVS, these major purchases. Like, we can't just pretend they're not happening, and they're not happening for a reason because of these exact same things. What do you think of that question overall? And can you kind of tie it into your experiences with doing the contracting method?
Yeah, I think you would just want to be careful, because there's one stipulation with chronic care management, any of the care management, is that it has to be established patient by the billable provider. And so when you look at that, you just got to be careful and make sure that the patients are under the care of that provider, have at least one visit with that provider. So say it's a nurse practitioner because you have a home healthcare business that's doing, everything for the patient at home. Maybe you could look at it like, can my provider go make a house call and set the stage for what that could really look like for the patient's needs and that kind of stuff, to be able to bill for these services, especially when we look at remote patient monitoring, or remote physiological monitoring is its CMS name. But yeah, I think there is opportunity there. You just have to dot the I's and cross the T's around that provider being an established patient. But yes, it's very doable.
I love it. Thea, wonderful episode. We're going to knock it out again next time, and you'll get to wrap more kind of dots together. Join Thea on her channel through RPH Ally. Go into the remote care services section and check out the documentation she has, and join the conversation there. We'll talk to you soon.
Take care.